Good afternoon, and thank you for joining us for this webinar. Here is the agenda for today. I want to begin talking just a little bit about looking at older adults as a group, and then, as I don't think was very clear in the title of the webinar, and I'm sorry, the focus of this webinar is twofold. One, looking at some of the issues related to working with older adults, and then two, kind of specifically looking at the contribution that occupational therapists play in older adult assessment. So the next thing on the agenda then is looking at some of the roles, again, that occupational therapists have in older adult assessment. I'm going to go through some additional areas of assessment or consideration when working with older adults, and then talk briefly about making referrals and the multidisciplinary team process. So there is really a lot of information to cover when talking about working with older adults, even if you kind of narrow that and think just about evaluating older adults in any setting. And so this is really kind of an overview with some details. But then at the very end, in the survey that you get at the end of the webinar, we've added a question today just to ask about, to kind of help gauge interest in looking more in depth at additional areas related to aging. And so if you can, I'd really appreciate your feedback at the end of the session. When you close out, you'll see then the survey that would help us provide additional webinars in the future. So as I mentioned, I want to begin just kind of looking at older adults as a group. This group of people 65 and older is growing at kind of an astronomical rate. This has been referred to as the silver tsunami. Some of you may know that in 2011, the baby boom group actually began to turn 65 as well. And when that started on January 1st of 2011, 10,000 people began to turn 65 every day. And from that point forward, for the next 20 years, so we still have another 16 years of that, up till December 31st, 2029, 10,000 people a day are turning 65 in the United States. The 65-plus population segment is projected to double to 71.5 million by 2030 and to increase to between 80 and 90 million by 2050. And that will comprise 20% of all the adults in the U.S. at that time. The 85-plus population is projected to increase to close to 21 million by that time. So simply by virtue of the growth of this older population, the need for older adult-focused services has and will continue to increase. And this is happening all over the world, not just in the U.S. You're looking at U.S. Census Bureau figures here, obviously. I don't have the world population figures available, but this phenomena is taking place across the world. The world's oldest population is the fastest growing. So currently, the older adult population is, you can see some information about them here. Again, they're defined as 65 years of age and older. That's a federal definition. This group as a whole is less racially diverse than the younger cohort. Ethnic minority persons constitute the fastest growing segment of the geriatric population, with an increase from about 5.7 million in 2000 to 8.1 million in 2010, and an increase, projected increase to 13.1 million in 2020. About 80% of this group have graduated from high school. About 20% have college degrees. Around 25% are employed. 60% are married. 30% living alone, and about 10% live in poverty. And currently, as I mentioned, older adults make up about 13% of the population, but they have a much higher rate of interaction with healthcare services. This is information from a report from the Institute of Medicine called Retooling for an Aging America, looking at building the healthcare workforce. And it really makes clear the need for work with older adults and the dearth of the workforce, or the prepared workforce that we have and that we're projected to have. So you can see that even though older adults only make up 13% of the population, they make up 26% of physician office visits, 35% of all hospital stays. They use about 34% of all prescriptions. 38% of all emergency medical service responses, 70% of home health services, 90% of all nursing home use. Of course, the last two of those make good sense. This group has multiple chronic conditions, and I'm going to talk some more about that. They also experience more mental health conditions. About 2/3 of older adults have multiple chronic conditions versus about 25% of the overall population, and about 20% meet the criteria for a psychological disorder. Older adults who have mental disorders may have different manifestations from younger adults as well, and older adults, again, frequently have coexisting chronic medical conditions. They have more cognitive impairments, more social stressors, including retirement and widowhood. We're living longer as Americans, but many of us will need to manage a host of chronic diseases, including things like hypertension and arthritis and heart disease, diabetes and osteoporosis, and dementia. So let's see. So just to make the point that older people really are different, because illness in older adults is complicated by physical changes of aging and by multiple medical problems. We see an atypical presentation of illness in most older adults. For example, subtle changes like a decrease in function or a diminished appetite very often may be the first signs of illness in an older adult. First sign of a problem may be some sort of nonspecific symptom such as a fall or some confusion, or maybe another type of symptom that just may signify an impending acute illness in an older adult. Changes in behavior or function in an older adult are often symptoms that are indicative of an approaching disease, especially for a frail older adult. And this group often presents, again, with multiple concurrent problems. They may often have nonspecific symptoms such as confusion or self-neglect or falling, incontinence, apathy, anorexia or weight loss, shortness of breath, fatigue. They may take to bed. They may have spells. They may have hidden illnesses as well, such as things like sexual dysfunction or depression or incontinence, alcoholism, hearing loss, memory loss. They tend to underreport their problems or concerns due to a lot of reasons, but including things like a belief that their symptoms are just due to old age, and that's really reinforced a lot in the media and even in the professional workforce as well. There may be a fear associated with reporting problems or concerns or denial. They may have concern about the cost. They may be embarrassed. It may be because of mental impairment. They may be concerned that they'll be removed from their home and then no one will be able to monitor or care for their ill spouse. They may have had a previous bad experience with the healthcare system. They may be afraid of institutionalization. So there's a lot of reasons why they will underreport, why their problems can go underreported. And they frequently have had multiple losses in a very short time, things like the loss of physical health, the loss of social contacts. Their friends and family are beginning to die, loss of familiar roles, job roles, a spouse, parent, loss of financial security related to retirement or widowhood, loss of independence and power, loss of mental stability, sometimes loss of their home due to forced residential change or relocation. And they suffer the expected physiological changes associated with age as well. And then they have, again, those changing social roles associated with retirement and changes in family structure and things like that. This slide shows some of the normal effects of aging on the body, and I think you can probably see most of that. The brain loses volume as we age, but the loss in volume really doesn't necessarily correspond to things like memory decline or mental slowing. As a matter of fact, memory loss that causes a problem with daily functioning or caring for oneself is not normal aging, even though people kind of, again, the media reinforces that as kind of a normal part of aging. It is not. Things that may be, though, are things like crow's feet and age-related hearing loss, a loss of skin elasticity, some benign forgetfulness, but not memory loss, decreased blood vessel compliance. Sensory impairment generally is not physically life-threatening, but it can be psychologically damaging. We'll talk some more about that, the visual and hearing impairments and how they can lead to a significant loss of independence, they can be really devastating to quality of life and impair access to proper treatment by minimizing good communication. Hearing impairment especially can lead to social isolation, especially since it's primarily self-reporting. And there's been a lot of recent research related to how sometimes this is kind of seen as the precursor to cognitive impairment. About 1 in 3 people in the United States between the ages of 65 and 74 has hearing loss, and nearly half of those over 75 have specific hearing deficits, especially the loss of high-frequency sounds, which makes it really difficult to understand human speech, especially when there's competing sound like in a crowd. Noise-related hearing loss also impacts age-related hearing loss, and high blood pressure and diabetes and, of course, some medications can also impact hearing. Normal declines in vision with aging include the things that, again, we hear about in the media and some of us are experiencing: diminished focus up close, diminished color perception and contrast sensitivity, and decreased vision in lower light. And then there's, of course, medical conditions that increase with age that affect vision, including things like macular degeneration and glaucoma and cataracts and diabetic retinopathy. And then taste is another of the senses that's altered through the aging process, and also because of certain conditions and medications. Altered taste, of course, really interferes with the pleasure of eating and then may lead to weight loss. Declines in motor speed and motor coordination and balance and gait occur with aging and may lead to problems, of course, in walking, including difficulty maintaining a uniform gait and balance. Falls due to a loss of balance and motor coordination are, as you can imagine, a major cause of serious injuries in older adults, and gait and balance problems are particularly related to falls because falls are a major source of injury and morbidity in older adults. 20 to 30% of older adults who fall suffer moderate to severe injuries that limit mobility and, of course, reduce the quality of life. And then looking a little bit again at cognition, it's a real common misperception, as I mentioned, that all areas of cognition decline with aging. The most common finding is slowed speed of processing. Crystallized intelligence remains intact, and we do see some declines in fluid reasoning. Problem-solving related to strategies previously learned remains intact, while novel problem-solving approaches are more difficult. Recall of past events tends to remain intact, while formation of new memories are more affected with aging. Simple attention remains intact, generally, while divided attention is more difficult. Language abilities tend to remain intact, but word retrieval is slower and may be more concerning to individuals. Mild cognitive impairment, just as I guess now an older diagnosis with the new DSM, considered neurocognitive impairment now. But mild cognitive impairment is observed in 10 to 20% of people over age 65. So I'm hearing some clicking, yet my phone still appears to be connected. So if I cut out, somebody needs to maybe type me a message in the message box or something. Somebody let me know if y'all can still hear me. Gary or Shelley, can somebody type me a message saying, yes, you can still hear me? I don't know if I'm still connected or not. Okay. Oh, thank y'all. Appreciate it. Sorry. I was hearing a lot of clicking. Okay. Let's see. The Census Bureau did a community survey in 2013, the U.S. Census Bureau, and it indicated that some type of disability, so difficulty in hearing, vision, cognition, or ambulation, self-care, or independent living, was reported by a little more than a third of people aged 65 and over, with about 23% having an ambulatory disability alone. And some of these disabilities may be relatively minor, but others, of course, cause people to require a lot of assistance to meet important personal needs. Okay. Many older adults develop what are called geriatric syndromes, and this is one or more related medical problems. They usually have more than one cause. They involve many parts of the body. Often one can contribute to another, of course. If you look at this list, you can see that would be the case. And that, of course, makes medical care for older people much more complicated. But looking at some of these, dementia, of course, Alzheimer's and vascular dementia are two common forms of dementia. There are others. But while some healthy people find it harder to remember things, as we mentioned, or carry out some mental activities, that really doesn't mean that they have dementia. For those that do, it does get worse over time, and it can really severely limit the ability to function. Confusion or delirium there. Many older adults who go to the ER or who are admitted to the hospital will develop delirium, which is a state of sudden confusion that can last several days or weeks or sometimes even months. And this is caused by things like dehydration or thyroid problems, pain, urinary tract and other infections can cause delirium, strokes, of course, heart or breathing problems sometimes. And older people can really develop very serious and very life-threatening complications and loss of function if delirium isn't recognized and treated quickly. Looking at sleep disorders quickly, these can certainly affect a person's quality of life and can contribute to falls and injuries and other health problems. There's a lot of things that affect sleep. We'll talk a little more about that later as well. Problems with eating or feeding, age-related physical changes, of course, medication side effects, dementia, and then other illnesses can make swallowing really difficult, which can lead to malnutrition and related problems. Other problems may be things like, choking when swallowing or even aspiration when food or liquid goes down the wrong pipe. Malnutrition is another issue related to problems with eating or feeding, of course. Many older adults need more of some of the nutrients such as calcium and vitamin D and B12 and things like that they aren't getting at an older age from their diet or medications cause problems with absorption, and so they don't have sufficient levels. Malnutrition can show up as weight loss or sometimes even weight gain, which can, of course, lead to other problems such as weakness and falls and bone disorders and even diabetes. Incontinence is another syndrome. Many things can cause bladder control problems or urinary incontinence, things like an overactive bladder muscle, a urinary tract infection. There's a lot of different contributing factors to incontinence, but urinary incontinence itself can lead to problems such as falls and depression and of course, isolation. Osteoporosis or thinning bones is a condition that makes the bones of older adults more fragile and easy to break. More common in people with a family history of this condition, or certain medical conditions and medications can increase the risk of osteoporosis. Pain we're going to talk about a little more later, as well as falls. Falls are the leading cause of serious injury in older people. And they usually have more than one cause too, just like these other syndromes, which is why it's listed here as well. Difficulty walking and gait problems. Of course, there's a lot of contributing factors to those that correspond with aging. Dizziness being one. Fainting is increasingly common with age and leads to falls. There's a lot of possible causes for that. Things like low blood pressure, low blood sugar, irregular heartbeat. Usually more than one cause for older adults. And then skin care, decubitus ulcers, also known as bed sores. This is when there's skin or tissue damage that's caused by constant pressure on skin and the soft tissue underneath it. So these are some of the special issues that the medical community will frequently deal with when they're working with older adults, and as occupational therapists, you will see many of these as well if you're working with older adults. So it's kind of clear that older people really aren't just young people with more birthdays. They have multiple chronic illnesses. 88% have at least one chronic illness. 60 to 65% have two or more chronic conditions. 50% of people over 85 have dementia. 50% of those over 65 are malnourished. 30% over 65 have urine control issues. Again, incontinence has really significant implications for the independence of older adults, and it's the second most common reason that families admit their older relatives to nursing homes. also associated with an increased rise in depression. It's not a normal part of aging. It's very stigmatized, also very underreported and underdiagnosed, and then, of course, undertreated. And as you can imagine, and I think I mentioned, it's associated with falls. 50% of people over 65 suffer from chronic pain, and chronic pain is defined as any pain that lasts longer than about 12 weeks. That's a lot of people. And then 7 to 10% of people over 65 are victims of elder mistreatment. That is a soapbox for me. I will stay off of it today, but maybe talk about it at another point. 33% of people over age 65 fall annually, and older adults consume, of course, lots of daily medications. So the average 75-year-old suffers from 3 chronic conditions and takes about 5 prescription medications. Older adults are more likely to have multiple chronic conditions, and people with multiple chronic illnesses are likely to have, or they're more likely to have, activity limitations. A significant portion have a disability. 50% of people over 85 have an ADL or IADL disability. 50% of those 75 and older have trouble hearing, and 22% of those 75 and over have vision limitations that are unclear. So these are some of the challenges we face as people who work with older adults. It can be a really complex area to work in, very rewarding, and I really enjoy the work that I have done and do with older adults. And I've worked with a lot of occupational therapists in a couple of different settings, and so I want to talk a little bit about the roles that occupational therapists play in older adult assessment now. And pretty much throughout the rest of this talk, I'm going to be talking about a lot of different areas of assessment. And so if I don't say, and here's what occupational therapy does, please don't assume that you're excluded from these evaluations or from the areas of assessment. Again, there's a lot to cover when thinking about working with older adults, and so I had to leave a lot out. So as you can see here, by 2030, and as I mentioned earlier, the number of older Americans will have more than doubled to 70 million, or 1 in 5 Americans. This is a slide that I took from a 2011 Occupational Therapy and Productive Aging, the Top 10 Things Everyone Needs to Know presentation, I think done by AOTA. Occupational therapy really is hands-on and very practical. Occupational therapy clinicians focus on what occupation or activity looks like in real life and collaborates with the clients and the family to help create a really workable plan for everyone involved. And occupation, of course, as many of you, most of you probably know, doesn't really just mean a workforce activity. It means activity. So even thinking about the activities, daily activities that are required after retirement or before paid work. The emphasis that an occupational therapist has on the therapeutic relationship really leads to client-centered goal setting, and individuals typically feel able then to share with occupational therapists what's meaningful to them. You're experts in activity analysis, looking at the demands of the activity, the barriers to performing the activity, what skills are required to complete the activity, how the environment affects participation in the activity, and even what the cultural meaning is, what cultural meaning has been ascribed to the activity. The profession of occupational therapy really evolved out of the medical model, but then it's evolved into the educational system as well, which is pretty much what we hear about most often. But there's some differences between an educational or school-based and a medical or community-based model of occupational service delivery. The medical model generally focuses on the impairment versus the education model that focuses on the functional outcome as it relates to a child's individual education plan. So the medically based therapy is generally provided in a more isolated setting, and the focus is on the components of performance or the impairment. So looking at maximizing strength and range of motion and quality of movement, things like that, in settings like hospitals and acute and long-term rehab settings, inpatient and outpatient settings, home care increasingly, community centers, clinics, day treatment programs, even in industrial settings. And the fundamental concern of the occupational therapist is that capacity throughout the lifespan, really, to perform to the satisfaction of the self and others those tasks and roles that are essential to productive living and to mastery of the self and the environment. It's a science-driven occupation, occupational therapy is. It's an evidence-based profession that helps people of all ages to live life to the fullest by helping them promote health and then prevent or live better with, in many cases, illness or injury or disability. So usually with the goal, of course, being to enable as much independence as possible for individuals in activities of older adults, work for some, but self-care and leisure as well. Obviously, the services will differ according to the age of the individual and the setting and the nature of the disability. But no matter those differences, the occupational therapist uses activity analysis and goal-directed activities to help the individuals be successful in whatever their activity is. These are just some of the core skills of occupational therapy, some of which I've already mentioned, but there's a variety of skills that you bring to the table when you work with older adults, and they can be really especially valuable in multi- or interdisciplinary work. There's been several studies done on the efficacy of community occupational therapy with older people. A Solchins et al. 2004 study, actually it was a systematic review related to the effectiveness of OT in maintaining independent community living for people age 60 and above. And they found strong evidence for the efficacy of OT advising on equipment to improve functional ability and some evidence for the effectiveness of OT in skills training alongside home safety assessments to reduce the incidence of falls in older people, and then evidence also for the effectiveness of OT in improving functional ability and social participation and quality of life for most older people. You have a really important role to play in helping keep older adults independent or as independent as possible and safe, in helping older adults and their families make informed decisions about things related, like decisions related to driving and independent living and level of care and types of assistance that are needed. You're skilled in prevention and lifestyle modification and physical and psychosocial rehab. And for many older adults, we don't expect major changes in health or function to be realistic, of course, depending on circumstances. But in many cases, small changes are what we work towards, and those can really transform the quality of life. And as you can see here, thinking about things like just regaining the ability to transfer can mean the difference between going back home or having to go to a nursing home. Regaining the ability to use your thumb and fingers can mean difference between eating independently and having to do that. And of course, that has implications for residents and level of care need as well. So looking at chronic health conditions in occupational therapy, because I've talked some already about about chronic conditions, we want to addressing performance deficits in daily self-care and home management tasks, things that result from specific chronic conditions. In order to sustain or improve current status in these areas are things that occupational therapists are helpful with and skilled at. Teaching strategies to incorporate energy conservation and activity modification techniques into daily activities to cope with the physical demands and reduce the fatigue associated with many chronic conditions. Individualizing adaptations to effectively perform health management tasks. So, making sure that someone with some weakness in their hands can manage daily insulin shots for diabetes, for example. Teaching and incorporating health management tasks into existing habits so that they become part of the daily routine, so sometimes setting up a schedule and a reminder system to take medications, and developing coping strategies and behaviors and habits and routines and lifestyle adaptations that support physical and psychosocial health and well-being. Look a little bit at prescription and over-the-counter drug use. People over the age of 65 consume more than 30% of prescription drugs and 40% of over-the-counter medications. The average 65-year-old will take 7.5 prescription medications during each year. Almost a third of all hospital admissions for individuals over the age of 65 are related to adverse drug reactions, and medication interactions also can occur when the action of one drug affects the desired action of another drug, so that would be an adverse drug reaction. Many elders are prescribed many medications for simultaneous use, in some cases more than 5 to 10. I have seen people with upwards of 20 medications, sometimes from different doctors, but sometimes even from the same. The phenomenon of polypharmacy really is not created with intent normally. Treating more than one condition really does require more than one medication a lot of times, and side effects of medications can require an additional medication. But polypharmacy really does lead to more adverse drug reactions and decreased adherence to any drug regimen. Here's just some of the side effects of polypharmacy. I'm going to skip quickly over some of these, but you can see that that adverse drug events can be linked to depression and confusion and falls and hip fractures and things like that.